I got a very valuable picture clicked some time back, where in the same frame I could take a picture with Dr. Samiran Nandi and Dr. Subhash Gupta. And I have learnt everything I have learnt in transplant and more from Dr. Subhash Gupta. And I suspect he may have picked up some things at some point of time from Dr. Samiran Nandi as well. And this is the high point of the conference, where we have Dr. Subhash Gupta talking about how he converted his initial failures into successes, a transition that is very important in everyone's lives. And for this session, I'm very happy to have Dr. Ashokananda Konar. May I welcome him to chair this session. So would you please come up on the dais? And I am aware that Dr. Konar is a very good friend of Dr. Subhash Gupta, and both of them would be mighty pleased to be here today. So may I request Dr. Gupta to please give his oration today, The Initial Years, Converting Failures to Successes. A little announcement that this is just an idea we had, that after this, when we do Dr. Nandi's interview, we would like all the people, the entire delegates and faculty over here, to join us after the interview on stage to have a group photo, which I'm sure we will all cherish. And we'll use the stairs to have 3-4 rows so that we can take this picture just after the interview with Dr. Nandi. Dr. Gupta, sir.
Thank you, Ramdeep and 𝐼SOT for giving me this opportunity. So obviously, when you are successful, or you think you are successful, then obviously whatever you've done seems right, and that's perhaps is the case. I don't think I've done actually anything actively to convert failures to success, but luckily for us and perhaps for the country, that liver transplantation is such a success now. So if you look at our journey, so very small numbers in the beginning, but gradually in 2013, for the first time, we crossed 300 transplants in one calendar year. And last year, we had the opportunity of crossing 400 transplants this year, in one calendar year. And Dr. Shalin tells me this morning that perhaps we are likely to cross 500 this year, but I'm not sure. So going back to the initial years, which is 1994, kidney transplants from unrelated donors was not uncommon. There was no legislation in place. Brainstem death was not recognized. And Dr. Nandi is here, and we're honored to have him here in the audience, was instrumental in getting the Human Transplant Act through the Parliament. Unfortunately, brainstem diagnosis and transplant forever got linked together. And that, of course, had its own problems, but we'll not go into that today. First successful transplant done in 1998 in Apollo, and the first successful transplant program was established in Sir Gangaram Hospital. And this is a young girl, Chandni, we transplanted in 2003, and for fulminant Wilson's liver disease. She had already lost 2 sibs. Father was the donor. The transplant was done for less than 6 lakhs, completely rehabilitated 20 years on and without immunosuppression. And this is a picture I got from her yesterday. Now, what is the background? Why so much discussion on failure and success? So to look at the nature of the liver operation, particularly living donor liver operation, which is technically challenging, carried out in a sick patient, where post-operative events are unpredictable, as normal healing is impaired, both from the use of immunosuppression and by the inherent nature of the operation. So if you have good healing, then you have rejection. So that's how it works. Living donor liver transplantation also puts at risk another healthy individual, which adds another dimension to the complexity of this operation. So not only you need to have technical skills, you need to have idea on how to control infection and prevent rejection at the same time. So what were our stumbling blocks in the beginning? And actually, to some extent, these stumbling blocks are still present. Pre- and post-operative management, interpersonal relationships are often a big issue, selection of patients, and of course, technical difficulties, which generally for a good surgeon, a good team, it's easy to master. So what are the problems that we face now? Whom to transplant? And this is all transplant surgeons and physicians will tell you this. Patients are either too well or too sick for transplant. So what do you do? Of course, you have sarcopenia and frailty that also impacts on outcome. The Western world has solved this by using a MELD sodium score, and this I've taken up from the net. And you see it's an arbitrary patient with a creatinine value, bilirubin, INR, and sodium. And this person gets 33 points, and the estimated 3-month mortality is 52%. So you have something that's widely sort of accepted here, that's easy for patients to accept transplantation because transplant operation is not without its risks. So it should only be considered when the risk of the disease is far more than that of the transplant. But the MELD score does not serve us well because many patients may have low MELD scores, creatinine values can be variable, lab differences between INR is different. So I sometimes think that perhaps the old-fashioned 𝐸𝐻 status B category is perhaps the best way of selecting patients with someone who had a Child-Pugh score greater than 10 or a score greater than 7, but with one additional problem such as unresponsive variceal bleeding, hepatorenal syndrome, bacterial peritonitis, or refractory ascites, hepatic hydrothorax. I think we should try and focus more on these because this is actually the most appropriate group of patients to operate. What about interpersonal relationships? Now, this is something that in a big program or even in a small program, this is a big issue because without the different sort of rings that are working together harmoniously, you cannot get success. So you give others credit for the success, but for the failures, you must take the blame. And I learned early on, and I'll tell you why, that you need to have very strong relationship with anesthetists and intensivists. And many people know that those you want to build up a program, you must be the first to reach and last to leave. And encourage discussion, and every opinion matters. Now, one of the problems that we've seen in the beginning was that whenever there was a problem with the patient, first thing that was said was that sepsis. Excellent shield for physicians, but it's important to realize that sepsis only becomes unmanageable when there's a breach in surgical, nursing, or ICU protocols. And if we keep this in mind, then perhaps we can be able to deal with sepsis better. No amount of antifungals or antibiotics will work if there is a problem with the operation. The old values in surgery, chest physiotherapy, fluid balance, weight record, oral hygiene, nutrition, early mobilization, actually the keys for success rather than fancy antibiotics or fancy tests. So one problem that we faced earlier on and then we corrected later was that we had an open ICU with the air handling units, which is common to all the areas. So now air in India and Delhi particularly gets very, is very polluted. These HEPA filters need to be changed every 6 months. So what we did then was that we created our ICU layout that of course brought about some nursing difficulties because we made cubicles like in OT, and then we merged ICU, HDU and isolation to one ward. The advantage of this was that you could then change the filters individually rather than having to close down the entire ICU. Now, technology, excellent, but still at bedside, assessment remains the strong point. Fluid balance, passive leg raising test is probably still the best tool. You can ask any intensivist. Stay by the bedside till the patient is better. And I can recall a story which Dr. Patrick Kama told in one of his presentations in India, that he just joined All India Institute and Dr. Nandi said, you sit by the patient and take him off the ventilator by the morning. And he sat by the patient and by the morning the patient was off the ventilator. So that's a success story, and see where he's reached now by just sitting by the bedside. Inotropes versus fluid boluses, you can choose either, but when fluid goes in, you must make sure it has to come out. Daily weight measurement and nutrition. These are some of the old things that are necessary for success. So we have some timelines in our program. In the first phase, which we call the learning phase, we looked at LDLT as an extension of DDLT operation from 2001 to 2004. We used veno-venous bypass. We had less emphasis on outflow reconstruction. We focused on CMV, rejection, and hepatic artery thrombosis, induction agents. And we gradually realized that they're not as important LDLT, so which is In the consolidation phase, we had dedicated intensivist who's like committed to the patient morning, evening, takes the phone calls, even when he's not on call as such. Education of nurses. And this has been a big problem in India because, and particularly in recent years, because during the COVID period, very few nurses actually went to see patients. And some of these nurses have been sort of let loose on the ward, if I may use that expression, and they need to be trained. And then you have to train members to be skilled in different components of the operation. And now, of course, we reached the stage of innovation. We're doing sick patients, those with renal failure, and we're doing sequential liver kidney transplants, ABOI liver transplantation, paired exchange and domino transplants, and now in the more recent months into minimally invasive donor and recipient surgery. So I just want to stress again that LDLT and DDLT are very different operations. Having spent many years in UK with over 500 DDLT experience, I was inclined to view LDLT as just another liver transplantation. But subtle outflows or problems are always there. And I can recall from a young boy, we'd done a combined liver kidney transplant for primary hyperoxaluria. Operation went beautifully. The child didn't have portal hypertension, so implantation, we thought it was perfect. Much later, we realized that there was outflow narrowing. We had done it piggyback style and without cable clamping. And recent years, we've focused more and more on subtle hepatic outflow obstruction. I think we now do it with a large growth factor. And I think that's something that perhaps has made a little difference in our program. So this is hepatic venous outflow. You can't do it interrupted, but it's too much time. So most centers are done continuous, but previously a bit reluctant to put a growth factor, but you can see here the anastomosis is done with a large growth factor, and this has made a little difference to our program. And this is becoming even more important nowadays because of the minimally invasive donor hepatectomy. There hardly any sort of the right hepatic veins are cut short. Now, one of the biggest problems that we faced in the beginning was the middle hepatic vein conundrum, as they call it. The Japanese did not stress on routine middle hepatic vein reconstruction. They said if you saw backflow on ultrasound or what, only then you should reconstruct. Then the Hong Kong group introduced MHV in the graft with excellent results. Professor Lee from 𝐴𝐶 Medical Center introduced the modified right lobe graft. And I must say that group, the 𝐴𝐶 Medical Center has now reported over 8,000 transplants without a donor mortality, which is amazing feat really. So we developed this clamp test, which is a very simple sort of operative, intraoperative sort of assessment of the anterior sector drainage. And you can see there's left side, which is ischemic, and right side has two parts, one darker and one lighter red. And that large part of the right lobe is drained by the middle hepatic vein. And if you didn't find good outflow reconstructing this, you're going to have poor outcome in the recipient. The surgeon and the anesthetist must work in concert. And I'll tell you an incident that happened a long time ago, in 2001, I think. We'd worked up a patient for living donor liver transplantation. We'd done many right hepatectomies. Well, Dr. Nandi had a very busy practice, and we did hepatectomies every day. So we did a right hepatectomy without blood loss, without inflow occlusion. We thought we were ready. Then the patient's sister was to donate, and then during the anesthesia checkup, our head of department of anesthesia told the potential donor that this was going to be a fast operation. That was the last time we saw that patient. So it's important to have liver anesthetists completely aligned with the surgeons, and just sort of good relationship with anesthetists always helps, because many of my subsequent referrals came from anesthetists. What about post-transplant management? We tried to simplify it. We just looked at it as 3 issues: technical, infective, immunological. And technical parts could be sort of ruled out by a good Doppler examination, drain fluid and milase. Try to remove drains early. Cholestasis is inevitable in recipient. We try and ignore it if the patient is well. And rising platelet counts are always a good sign. Septic patients are rarely aggressive, and if withdrawn, that means they have a collection inside. So these are things that we learned from our program. And then we introduced what we call the sort of 48-hour trial period. So we thought if you're not sure whether it's infection or rejection, then you increase the immunosuppression. If you thought it was rejection, for 48 hours, see the response. If not, then you made an about turn. That simple policy helped us a lot. Rejection in living donor liver transplantation is not a devastating diagnosis, as we had been trained in disease donor liver transplantation. We did frequent liver biopsies, and my typical sort of morning in Birmingham used to be 6 liver biopsies almost every day. And the most important, and this is also sort of analogy from kidney transplantation, where technical issues are almost non-existent. So liver biopsy and pulse is always the tool for altered graft function. Now, liver biopsy in small grafts is not an easy proposition. Congested, risk of bleeding, and rarely is post-transplant biopsy report as being normal. So often you are sort of forced to put the clinical picture together and then make a decision. In those days, of course, transjugular liver biopsy is unheard of, but now, of course, that has made life very easy. Since then, we've come a long way. Ultrasound skills have improved markedly. And initially, we focused only on hepatic artery patency, but now our ultrasonologists will look at small hepatic veins, look at anterior and posterior portal veins, and they'll alert us much more in advance about changing flow dynamics and having a good interventional radiologist. Hepatic pressure measurements and biopsies can also be combined for managing these patients better. Again, I recall an incident which was one of our failures at that time. 50-year-old lady, sick lady from Ganganagar. She had a very smooth transplant, male donor. We extubated. The chest X-ray next day showed some infiltrates. We panicked. So we advised to dry it out, which we now know is the wrong thing. And she said then went on with sort of multi-organ failure and died. Of course, we didn't realize at that time that these are people who just need to be maintained on non-invasive ventilation with a BiPAP mask for a while, and they will do well. His donor gave us more trouble because we trained to putting stockings in them, and of course, some amount of fluid retention is inevitable with major liver resection, and and then he ended up with chest symptoms. Unfortunately, recovered. And since then, we stopped using TED stockings for these patients, just mobilize early, and that seems to be working well. We also took help from other specialists, things that were not available to us at that time. It's very amazing to see Dr. Bejel and our own interventional leader, Dr. Sanava, do amazing procedures. In those early days, it was very difficult for interventional radiologists to be around to take us out of our difficulties. So our cardiac anesthetists provided a lot of help to us. They did cardiac outputs, arrhythmias, and sequelae of reperfusion syndrome. And the cardiologist himself was a big help. Not only sort of they did the angiograms, we stood next to them to explain the anatomy to them, and they would then do whatever was needed. Nephrologists and kidney transplant surgeons, because they had much more knowledge of infective complications, HLA mismatch, and we took their help. So nowadays, I'll often ask, what does it take to start a liver transplant program? I'll say, if you're doing cardiac surgery and you have renal transplant in-house, then it is equal to liver transplantation. In the beginning, we had amazing shortage of venous grafts, cadaveric grafts, which really just not available. So it's almost by accident that we started using the portal vein and umbilical vein, and that have worked beautifully. And we've used this in different situations, such as portal vein thrombosis, when we want to do the operation. We had a big issue with hepatic artery dissection, and many transplant surgeons will tell you that if this happens, how it makes the night miserable. So we developed a technique to doing anastomosis to hepatic artery, which Dr. Shalin published in liver transplantation, this technique, and that has helped us a lot. In the beginning, we were very keen to prevent, as I said, the entire focus was on preventing hepatic artery thrombosis. Again, tacrolimus with 𝐒𝐿, we lost many patients who developed neurological complications. And more recently, we transplanted somebody from a cadaveric graft who had gone into a recipient who again on aspirin. He became sort of intracranial brain dead, and we successfully used this liver once again. We've now come a long way in understanding small foci syndrome. It does happen, but more often than not, it's a technical issue, and anti-sector drainage is perhaps the key issue here. And Dr. Bapaditya Har is here, published this paper that even if your inferior hepatic veins are blocked, your graft lies in orthotopic position and the outflow is better. And this is someone who is a patient actually from Calcutta. He had the first post-op day, the lactates would just not improve. So we did urgent Doppler, and we found that the middle hepatic vein had thrombosed, and then IR person put a stent in the middle hepatic vein, and he made a rapid recovery after that and was discharged. We made a lot of stress from hyponatremia, again from DDLT days, that hyponatremia was a big problem. But we realized that as long as you maintain the sodium post-operatively, did not allow it to rise, none of them would have demyelination. Because we looked at hyponatremia more as a sick patient needing urgent transplantation than a need to correct them. Hepatic artery thrombosis does continue to be a problem every now and then, but thankfully to wonderful IR techniques, this is something that happened really 10 days ago, and we managed to get the hepatic artery going again. Transplant in portal vein thrombosis, it took us a little while to, first we realized that it was an inflow problem, that you wouldn't get an inflow. But more often than not, inflow is always there, but the bowel tends to be edematous, and that is where the problem is with the, and then you'll get a late bile leak, and once you get a late bile leak, you have all sorts of problems. So bowel anastomosis is probably what we need to focus on in complete portal vein thrombosis when we're doing transplants. We also looked at combined liver and kidney transplantation, because in this period where such sick patients who come for transplantation, renal impairment, and the end of living donor liver transplantation, the patient acidotic, not on inotropes, hypotensive, and you ask any kidney surgeon, they will not be happy in putting a kidney at this stage. So because of the initial sort of failures, we developed sequential liver kidney transplantation, and particularly if the patient has a good vascular access, you can safely do a liver transplantation. A few months later, you can do his kidney transplantation. And now we have actually a series of 5 patients who had successful kidney transplant from the same donor who gave the liver earlier on. I think one of our landmark publications has been that the graft weight has far more importance than the ratio. So once you cross 650 grams, really the graft ratio has little meaning. And this, I think, has been one of our major contributions in LDLT. Common sense and history taking. I think this always works, and I'm going to take you back to a true incident. This is a 50-year-old engineer who presented to us for a second opinion, as he'd been told that he had severe tricuspid regurgitation on a background advanced liver disease. And history revealed that only a few months ago he had a normal echo. He'd not had any acute event to suggest papillary necrosis or infarction. And he had a diagnosis cirrhosis, of course, and we looked at his PA pressures as markedly raised. We admitted him, although the creatinine was raised. We put him on intravenous furosemide, and 15 days later, we were able to transplant him, and he's still alive after so many years. Size matching in small babies, they have a high sort of portal vein thrombosis rate, so unless the grafts are small. So we developed the medial reduction technique, which we published in liver transplantation. Followed by that, we also did on-table extubation, and these 2 factors have allowed us to transplant small babies successfully. Shortage of organs always been there, so we done many newer methods for this. Paired exchange liver transplantation, ABOI living donor liver transplantation. We now have 120 patients who we've done ABOI liver transplantation. Older donors, we sort of have a series of 60 posterior sector grafts, and more recently we published how we've used 13 domino grafts for transplantation as well. Moving on to more current times, where sort of minimally invasive is becoming the key. So we do sort of graft extraction by small incision. Shaleen and others in the team have mastered this technique. Full laparoscopic robotic liver mobilization. And then you divide the bile duct, and then you remove the graft by a small midline incision, as you can see here. Saves costs, staplers are not used, and also decreases warm ischemia. And as far as pain is concerned, I think it's the same as with the Fanon-style incision. Can do precise stitching and division of the bile duct, and as I said, reduces warm ischemia time. So what have we learned from all this? Teamwork and multidisciplinary approach, nurturing talent in young surgeon, audit, identify what works and what does not, common sense approach where scientific wisdom is lacking, and pattern recognition. And I think this has been the key in moving ahead. And in the end, first of all, I'd like to thank Dr. Ramdeep and ISOT for giving me this opportunity, and also to invite you to the 6th World Congress of International Living Donor Liver Transplantation Group meeting in Jaipur this year, 17th, 18th and November. Thank you. We look forward to seeing you and welcoming you all there. Thank you very much.
Thank you, Subhash, for an excellent talk. I think we might take some questions.
I'm open to it.
Please, any questions or queries to Subhash?
Thank you, Subhash, for a really wonderful, insightful lecture and sharing your experience. I think you touched on some really important points of team working and team building. So my question to you is, when you do get a failure, how do you handle it? It'll be something that probably this audience would like to know. How do you handle a big failure? And how do you get your team together to go back and play the game again?
Yeah, I recall, I can tell you an incident that happened in another center. So the first day after the operation, the senior surgeon sees the patient, starts falling ill, then the senior resident goes, and patient gets a little bit more sick, then the junior most fellow goes, and then a few days later, it's only the anesthesia senior resident is seeing the patient. And if you do this, then obviously you're going to get into trouble. I think G.V. Rao once told me that if there's a problem, you need to, the senior most person has to face it and meet all the family members, spend far more time, and keep all the rest of your team out of it. And only then you can get out of it.
Thank you.
Sir, everyone here has someone he calls his mentor, and a lot of people here would count you as their mentor, me including. A lot of what I've learned, almost all of, big proportion of liver surgery and transplant of what I've learned is from you. So thank you for imparting the education to all of us. I have two questions for you. You have achieved so much. What is the one thing you count as your greatest achievement? And what is the one thing you would like still to achieve in the rest of your career?
I think the second question is relatively easy to answer. I think living donor liver transplant or transplant as such makes a great difference, and I think it should perhaps be popularized more. It should be in government hospitals much more than it is now, and it should also, nobody should not have a transplant just because they cannot afford it. I think this is something that I think I would like to work towards. As far as my biggest success is concerned, I don't know whether I've actually had but if I had to narrow it down to surgical thing, then I think some of the big things have been that for me has been separating liver and kidney transplant. That I think was a big problem for me, and being able to do a liver transplant operation, somebody with renal failure, I think has been one of the biggest sort of, in fact, Dr. Shweta is here, and we've actually done away with the intraoperative CRRT in the theater, just simplified the process so much that you can actually do a liver transplantation in somebody with renal dysfunction successfully. I think has been, again, a good, of course, there'll be disagreement by many people, but I think you cannot do a sort of 12-hour procedure and then have a kidney implantation at the end of it. So spacing it out, making it sequentially, I think has been one of our major sort of contributions.
May I have one question? I mean, do you see that we can do transplant without immunosuppression in coming days? I mean, in liver transplant especially.
Probably yes. Why? With so much work going on in, I think we just saw a report, somebody had bone marrow transplant and then successful liver transplantation without immunosuppression. Saw that report. Then we've seen reports of T regulatory cells and tolerance. But to be honest, liver is immunoprivileged organ. Immunosuppression as such has not been a major issue as far as liver transplant. I mean, we transplanted many of your patients, and so, I mean, so many of them after 15, 20 years, there's still sort of hardly any dose of immunosuppressant. Showed one slide of a girl 20 years ago was transplanted on me. For as far as liver is concerned, the challenge is in the beginning where technical issues are there, but immunosuppression really is not such an issue in liver. But yes, if we could do it without, but I think some work is going on. But as of now, the other thing is that in recent years, there's hardly been any new drug because the pharma industry and the sort of it's such a small sort of use of these medicines that no new drug has come in as well. But yes, I think if we could do it without immunosuppression, it would be fantastic.
Subhash, that was a very, very fascinating. This is Gaurav from Newcastle. You talked about that patient where you felt you're ready and the anesthetist said, this is the first operation. And it is quite a challenging situation, and we have faced it as well when we tried to introduce robotic surgery in our unit. And the first Whipples, the consent process was quite stressful for the whole team. And you have introduced lots of new things in your practice. How do you approach it?
So I think if we must present number on united front. There should not be naysayers in the team. So if they all, they all be committed. Because at that time we didn't realize we as sort of GI surgeons, general surgeons, we kind of never looked at anesthetists as being such an important component of the team. Subsequently, of course, we realized that this operation is actually done by anesthetists, not by surgeons. And so we put in protocols so that we have good relationship. So coming more specifically to the question, how do you introduce a new procedure to a patient? I think the best way to do it is in steps. This is how we did it for the minimally invasive. And I don't know whether Dr. Shalin is here or not. In the beginning, we said we will not do it completely. We all laparoscopic surgeons, we all do the procedures. We'll do components that we are comfortable with and gradually step it up rather than be the first one in the world to report robotic implantation or this. Once we've ourselves mastered it, only then we'll give it to our patients.
Thank you.
If there is no further question, I would close the session. Thank you, Dr. Gupta. And please give a big hand to Dr. Gupta. Thank you.